So let us read about mitral stenosis. What is stenosis? Stenosis is something related to narrowing. Narrowing of anything is called as stenosis. Over here, mitral valve, that is bicuspid valve, is getting narrowed, so it is called as mitral stenosis. Coming to the definition, a valvular heart disease characterized by narrowing of the orifice of mitral valve due to structural abnormality of mitral valve apparatus. Because of an abnormality of the mitral valve, there is narrowing of the orifice, that is opening of the mitral valve, leading to a heart disease called as mitral stenosis. Okay, the etiology, rheumatic fever is the most common cause. As we have read in the acute rheumatic fever, the hallmark is that it affects the valve. So over here it is affecting the mitral valve, leading to the stenosis of the mitral valve. The rheumatic fever is the most common cause in the etiology. It might be congenital, it might be severe mitral annular calcification with leaflet involvement. See over here what's happening is that there will be calcification of the annular calcification of the mitral valve that leads to the stenosis of this opening, right? So that is what it is over here I have said to you. And the systemic lupus erythematosus and rheumatoid arthritis. Myxoma, oma is related to tumor, and myxoma is nothing but gland. Because of glandular development, it is not metastasis or it is not related anything to the cancer, but there is a development of glandular or connective tissue that leads to the mitral stenosis. And infective endocarditis with large vegetation is also comes under the etiology of the mitral stenosis. And the MV orifice area, mitral valve orifice area, normally its area, that area is 4 to 6 centimeters square, whereas in mitral stenosis it is less than 2 centimeters square, and in very severe mitral stenosis it is less than 1 centimeter square, and in severe mitral stenosis it is 1 to 1.5 centimeters square. And coming to the hemodynamic hallmark, it is abnormally elevated left atrioventricular pressure gradient. I will explain you this after explaining you about the pathophysiology. What's happening in the pathophysiology is there is mitral stenosis that's increasing our left atrial pressure. See what's happening over here is this is our left atrium and left ventricle, right? So left atrium and ventricle, there is mitral valve over here, but there is narrowing of the mitral valve, so the blood cannot be pumped efficiently from the left atrium to the left ventricle. That leads to the collection of blood, or more collection of blood, and leading to the increased pressure in the left atrium. Okay, there will be more and more pressure in the left atrium. As we know, this left atrium, the pulmonary veins are connected to the left atrium. So whatever the pressure that has been built up in this left atrium is getting transferred to the pulmonary veins. So there will be pulmonary veins hypertension. In chronic conditions, that leads to pulmonary arterial hypertension. Okay, so what's happening? Mitral stenosis, there is increased LA pressure, increased left atrial pressure, that leads to atrial fibrillations and left atrium failure. Subsequently, there is pulmonary venous hypertension, as I have explained you with this, and there is pulmonary arterial hypertension. There will be pulmonary venous incompetence and pulmonary resistance. That leads to what's happening over here is this, as I have said, that there will be pulmonary artery hypertension. See, this is right ventricle, right? This right ventricle is connected to the what it is connected to the pulmonary artery. It is connected to the pulmonary artery. So this right ventricle, there is hypertension in the pulmonary artery. That means there is more vasoconstriction happening in the pulmonary artery. So the right ventricle has to push the blood into something which is already vasoconstricted, right? So it is already vasoconstricted, and the right ventricle is putting more and more efforts to push blood into something that is already vasoconstricted. So what happens is that because of sustained efforts of the right ventricle, there will be hypertrophy of the right ventricle. So because of this hypertrophy of the right ventricle, we will be able to see parasternal lift, also called as parasternal heave. Okay, so we are done with pathophysiology. I will repeat it once again. Mitral stenosis, because of the mitral stenosis, there is increased left atrial pressure causing atrial fibrillation, that leading to the left atrial failure. This left atrial pressure this pressure is being transmitted to the pulmonary veins, leading to the pulmonary venous hypertension, ultimately pulmonary arterial hypertension, leading to the pulmonary venous incompetence, leading to the pulmonary resistance. That is leading to the right ventricular hypertrophy. This right ventricular hypertrophy leads to the dilatation and right ventricular failure, thus finally leading to the secondary tricuspid regurgitation. But the tricuspid valve over here is the functional. Okay, coming to the symptoms. Over here the symptoms are progressive exertional dyspnea, orthopnea, hemoptysis, pulmonary infections, palpitation, systemic thromboembolism, chest pain. I will explain you reason behind this symptoms. Okay, why there is progressive exertional dyspnea? As I have said, there is built-in pressure. There is more hypertension in the pulmonary veins, pulmonary capillaries, and also in the pulmonary artery. So there is more and more pressure in the blood vessels, right? So what happens is that over here, from here, whatever the constituents are there, it will get transmitted to the interstitial. So interstitium, what it might be, the water or whatever it might be, it will get transferred to the interstitium of the lungs. Okay, it will get transferred to the interstitium of the lungs. So we will see, as a result, there will be edema of the lungs. Because of this edema, there will be orthopnea, progressive exertional dyspnea. And because of this edema, it may also lead to the infections. Okay, it may also lead to the pulmonary infections. So over here, what happens is that there will be progressive exertional dyspnea, orthopnea, hemoptysis, pulmonary infections. Because of atrial fibrillations, we also have palpitations. And as I have said, there is more and more blood getting collected in the left atrium. Because of the I have said there is more and more blood getting collected into the left atrium. Because of the collection of the blood in the left atrium, there is the formation that leads to the formation of thrombus. Okay, this thrombus gets dislodged and leads to the formation of thromboembolism. And there may be chest pain. Coming to the pulmonary changes, as there is edema that leads to the fibrous thickening of the walls of alveoli and also the pulmonary capillaries, that leads to the decreased vital capacity, decreased total lung capacity, and such changes are seen. And coming to the inspectory and palpatory findings, we can see mitral phases. What's happening? There is all over here in the mitral stenosis, there is peripheral vasoconstriction. But what's happening in our face? There will be dilatation of our blood vessels, because of which the face of the patient gets red, pinkish. That is called as malar flush. Okay, mitral phases, cyanotic lips and face, malar flush is seen, and there will be prominent A wave. Actually, in a normal individual, A wave is produced as a result of right atrium. When right atrium gets contracted, that leads to the production of A wave. What's happening over here is that because of all these things, there is right ventricular hypertrophy, right? So because of this right ventricular hypertrophy and all the changes, the right ventricle becomes stiff. Okay, so over here what's happening, the right atrium is pumping blood into something that is stiff, so it has to put more efforts to pump the blood into the right ventricle. Okay, so as a result, the right atrium is putting more effort, so there is production of prominent A wave. Okay, prominent A wave. And parasternal lift, I have explained you, because of the right ventricular hypertrophy, there will be parasternal lift, also called as parasternal heave, and there will be palpable P2. What is this palpable P2? Okay, what is this palpable P2? This palpable P2 is nothing but it is pulmonary component. Okay, it is pulmonary component of the second heart sound due to forceful pulmonary valve closure. Usually we will not be able to hear this or palpate this, but in this, what's happening in this mitral stenosis, we are able to palpate this P2. How are we able to palpate? Because what's happening over here is that there is forceful pulmonary valve closure, right? The blood is being entered from right ventricle to the pulmonary artery, and the closure of the valve, pulmonary valve is very forceful, because of which we are getting palpable P2 because of the pulmonary hypertension. Coming to the auscultatory findings, it is the auscultatory findings: loud S1, loud S2. In early stages, we are able to hear loud S1. In later on, due to accentuated P2, we are hearing loud S2. Accentuate, meaning of accentuate is nothing but prominent. Because of the prominence of P2, we are able to hear loud S2 sound also. And there will be opening snap of MV. There will be opening snap of mitral valve. Audible in expiration, while the patient is expiring the air, we will be able to hear this. Okay, where we are able to hear just medial to the cardiac apex. Okay, just medial to the cardiac apex, we are able to hear the opening snap of the MV. Okay, and next, low pitched rumbling mid-diastolic murmur with pre-systolic accentuation. Okay, accentuation is not but prominence. Heard best at apex with patient in left lateral recumbent position. Accentuated by mild exercise. On mild exercise, it will be more prominent. Okay, the duration of the murmur correlates with mitral stenosis severity. If you are able to hear this murmur for longer period of time, that means there is severe mitral stenosis present in this patient. Okay, and the fifth auscultatory finding is pansystolic murmur. The pansystolic murmur at left lower sternal border. It is nothing but it is produced by functional tricuspid regurgitation due to severe pulmonary hypertension. Okay, due to severe pulmonary hypertension, there is pansystolic murmur. It is louder during inspiration and diminishes during forced expiration. This is called as Carvalho's sign. Please do mention in your university exam few signs so that it will fetch you good marks in your university exams. And there is Graham-Steele murmur of PR. You just mention this, it's enough, but let me tell you what is this. It is high pitched diastolic decrescendo. Because decrescendo, the meaning of decrescendo is that there is decrease in loudness. Okay, there is decrease in loudness of blowing murmur along left lower sternal border. Coming to the investigations, we are doing ECG, echocardiogram, chest x-ray and cardiac catheterization. Okay, coming to the ECG, we are able to see p-mitral. What is this p-mitral? There is a notch in the p wave. Okay, this is the normal p wave, right? There will be a notch present in the p wave. Why is this notch getting over here? What happens is that there is right air, because of the, as we know, this is because of the depolarization, right? Because of the depolarization, there is production of P wave. Okay, right atrium depolarization occurs first, right? There is right atrium, left atrium. This right atrium gets depolarized first, and this left atrium depolarization is getting delayed. Okay, because of this prolonged depolarization of the left atrium, we are getting a notch in the P wave. Okay, why is this getting delayed? Getting delayed? Because because of the mitral stenosis. That's it. And echocardiogram, TTE, trans and TEE. TE is nothing but trans esophageal echocardiogram with color flow Doppler. What can we observe over here? There is thickening of the mitral valve leaflets and calcification. Okay, and there is thickening and shortening of the chordae tendineae. We are reading about the mitral valve, we are reading about the mitral stenosis, so there is thickening of the mitral valve leaflets and also the calcification of it, and there is also thickening and shortening of the chordae tendineae, and there is fusion of commissures. Okay, just remember this. And then chest x-ray, there is straightening of the upper left border of the cardiac cell head. See, obviously as the left atrium pressure is getting increased, the left atrium will get bulged, right? This what it is telling, straightening of the upper left border of the cardiac cell head. Okay, this upper left border gets straightened up, right, because of this bulge. That's it. And there is prominence of pulmonary artery segment. Okay, as I have said, there is pulmonary hypertension, there is prominence of pulmonary artery segment, and there is dilatation of the upper lobe pulmonary veins. Okay, dilatation of the upper lobe pulmonary veins. As we have lobes in the lungs, These pulmonary veins in the upper lobe are very prominent in this. Dilatation of the upper lobe pulmonary veins, and there is posterior displacement of the esophagus. Yeah, as there is right ventricular hypertrophy, as the left atrium pressure is being increased, there will be posterior displacement of the esophagus. There will be posterior displacement of the esophagus. Okay, next, Kerle B lines. What are these Kerle B lines? As I have said you, there is edema. There is edema of the lungs. Okay, right? There is edema of the lungs that leads to, because of the pulmonary venous hypertension, that we have edema over here. So what's happening is that this edema, because of this pulmonary venous hypertension, this is seen as short horizontal lines at lung base. At the lung base, we are able to see as short horizontal lines, which are called as Kerle B lines. Okay, and next, cardiac catheterization. Cardiac catheterization is something we do in investigation. It is not usually done these days. Okay, coming to the differential diagnosis, it is not usually asked, but just remember: mitral regurgitation, severe aortic regurgitation, tricuspid stenosis, and atrial septal defect, left atrial myxoma. And coming to the complication, just remember this: atrial fibrillation is the most common, systemic thromboembolism, pulmonary hypertension, infective endocarditis, Ortner's syndrome. Ortner's syndrome is nothing but there is hoarseness of the voice because of the compression of the left recurrent laryngeal nerve, and right heart failure and pulmonary infarction. Just remember this part. Coming to the main part, management. Okay, we are now dealing with the management. The penicillin, as in acute rheumatic fever, we treat with penicillin, right? As the most common cause is rheumatic fever, over here we are also treating this with penicillin prophylaxis for secondary prevention of rheumatic heart disease, and also infective endocarditis prophylaxis, because in etiology we have read that the most common cause is rheumatic heart disease, and infective endocarditis is also one of the reason for this mitral stenosis. And restriction of salt intake and diuretics for dyspnea. Okay, as there is already edema in the body, in the lungs, we are restricting the salt intake and also the diuretics. And for atrial fibrillations, we are using beta blockers, non-DHP calcium channel blockers, digitalis, warfarin, cardioversion. Cardioversion is such a medical method where the high pulse rate or more palpitations of the heart are being reduced. Okay, it's a medical method where the palpitations or where more heart activities gets reduced because of that medical method. And coming to the surgery, that is percutaneous mitral balloon valvotomy, PMBV, open valvotomy using CP bypass, and mitral valve replacement. So this is the management that we do in the mitral stenosis. Okay, hope you understand. Please like, share and subscribe. Thank you.